So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is the correct, and after, let's discuss this test step by step. So it's 69-year-old man. His major complaints is fatigue, jaundice, and weight loss over the past few months. Among them, jaundice is the most specific symptom, which tells us about high bilirubin level. In addition to this, he also reports intermittent fevers and night sweats. Fever and night sweats together look like a typical B symptoms. On physical examination, patient has lymphadenopathy, hepatomegaly, and splenomegaly, which together are very important features for diagnosis, because there are not so many disorders which can cause increase in size of all these lymphoid organs. His hemoglobin is 75, which is low. Decrease in hemoglobin we call anemia. Anemia explains his complaints on fatigue, and we know that anemia classified based on severity and the size of red blood cells. To determine severity of anemia, we have to know two numbers. It's 110 and 80. Also in this case, it's a man, and the lower limit of normal of hemoglobin in men is 130. So from 130 to 110 is mild anemia, from 110 to 80 moderate, and lower than 80 is severe. In this case, hemoglobin is 75, so it's severe anemia. The type of anemia we determine by the size of red blood cells. And to determine the size of red blood cells, we look at MCV. In case of MCV, we have to know two numbers. It's 100 and 80. Everything above 100 is macrocytic, between 100 and 80 normocytic, and lower than 80 is microcytic. In this case, MCV is 91, which is normocytic anemia. And as we see, red blood cells are also low. So in this case, patient has severe normocytic anemia. In addition to this, we see elevated white blood cell count. Leukocytes are 47, which is very high. And we also see very high percentage of lymphocytes. So in this case, leukocytes are elevated due to the increase in lymphocytes. And increase in lymphocytes with increase in white blood cells we call absolute lymphocytosis, which is a diagnostic criteria for chronic lymphocytic leukemia. And from physical examination, we know that patient has lymphadenopathy, hepatomegaly, and splenomegaly, which can happen in chronic lymphocytic leukemia due to the accumulation of mature malignant lymphocytes in the lymphoid organs. So we determined the major disorder. But the question is, what is the mechanism of anemia in this patient? And as we see, there are also alterations in reticulocyte count, in bilirubin, and in lactate dehydrogenase. We already determined that it's normocytic anemia. And normocytic anemia typically develops due to the acute bleeding, which causes acute posthemorrhagic anemia, or due to the destruction of red blood cells, and we call it hemolytic anemia. So we have to exclude these two types. Why it's not acute posthemorrhagic anemia? Because there is no signs of bleeding, and also there is high bilirubin. And high bilirubin is not typical for acute bleeding, but high indirect bilirubin is typical for hemolytic anemia. And if we suspect hemolytic anemia, the first feature we are looking at are reticulocytes. Reticulocytes should be elevated. The reason why it's so important is that it helps us to exclude other types of anemia. Because sometimes combination of iron deficiency and folate deficiency, for example, can also cause normocytic anemia. The logic here is that in microcytic anemia, we cannot produce hemoglobin. In macrocytic anemia, we cannot produce DNA, and thereby we cannot make red blood cell cytoskeleton. So in both this anemia, the ability to produce new red blood cells is limited, and thereby reticulocyte count will be low. But in hemolytic anemia, we do not have problem with red blood cells production, we have problem with red blood cells destruction. And because we can produce new red blood cells, in response to hemolysis, bone marrow begin to produce more red blood cells precursors, which are reticulocytes, so reticulocyte count will be elevated. Also, this patient has elevated lactate dehydrogenase, which is also typical for hemolytic anemia, simply because lactate dehydrogenase is the enzyme contained inside the red blood cells. So with red blood cells destruction, lactate dehydrogenase will enter into the blood, which will cause increase in lactate dehydrogenase concentration in the blood. The same principle works with bilirubin. In this case, bilirubin is elevated due to the increase in indirect fraction, and we know that the most common reason for elevation of indirect bilirubin is hemolysis of red blood cells. Additional marker of hemolysis, which is not mentioned here, is decrease in haptoglobin. So at this point, we know that it's definitely hemolytic anemia. But hemolytic anemia has several subtypes. Which subtype is it? And now, the most important feature is to understand the underlying condition which could cause hemolysis. So in test, once you see hemolytic anemia, you're looking for medications, intake of fava beans, autoimmune disorders, etc. In this case, the only feature that we know is that he has chronic lymphocytic leukemia, and it's enough to suspect autoimmune hemolytic anemia, because we know that chronic lymphocytic leukemia has two complications. It's autoimmune hemolytic anemia and immune thrombocytopenic purpura. The reason is that in chronic lymphocytic leukemia, malignant lymphocytes that live eternal life at some point begin to produce autoantibodies against own red blood cells and platelets. So, knowing that it's hemolytic anemia in patients with chronic lymphocytic leukemia, we can say that most probably the mechanism is immune-mediated hemolysis due to the production of autoantibodies, a condition known as autoimmune hemolytic anemia. Also, we can exclude other options, because folate deficiency causes macrocytic anemia with MCV more than 100. In this case, it's normocytic anemia. Infiltration of the bone marrow by leukemic cells occurs in acute leukemia, but in acute leukemia, pancytopenia should be present. In this case, platelets are normal and leukocytes are high due to the mature lymphocytes, not the blood cells. And pernicious anemia is a subtype of B12 deficiency anemia, and we know that B12 deficiency causes macrocytic anemia with MCV more than 100.